to care for people, to look after people with uncontrolled tumours who are dying of those tumours, and it's a particularly difficult thing. I think it's difficult for the patient and for their family. It's also difficult for the nursing staff and for the doctor. And the long-term ambition is really to turn this disease round. My name is Professor Richard Shaw. I'm a head and neck surgeon. I have an appointment as a consultant, a head and neck surgeon at Aintree Hospital NHS Foundation Trust in North Liverpool. It's one of the largest head and neck surgery units in the UK. And I also work in the University of Liverpool as a senior academic. It's better than it was, isn't it?
Oh,
I mean, there's not even a hint of redness or any hint of healing problem. The aim of what we do is to provide the revolution improvement in patient care, in the treatment we offer, in the outcomes in terms of patients' function, how many patients live or die after being diagnosed of cancer.
When he first looked at it, he said to me, "It's cancer, that is cancer."
And I'm saying, well, you may be wrong. You panic, don't you? Because you don't want to hear that word. It's such, at the time, it seemed like a death sentence, that word cancer.
So somebody like Stan presented, unfortunately, quite a large tumour and had to have a big operation and have quite a big segment of his lower jaw and the front part of his tongue and part of his lip removed. And that, I think, was curative for him. It's 4 years ago, and we've discussed that with him. But what we did on the day is take a segment of his shoulder blade connected to a blood vessel, and we reformed the shoulder blade into the shape of the jaw and put that in place with titanium plates, and actually had to sew the blood vessels end to end together down the microscope so that he has a new living jaw straight away.
Stan's still here because of him. There's that much research now and that much getting done. That it's not, you know, look, there's Stan, he's came through it and he's fantastic.
Would you say it's given you more confidence generally,
Oh, yeah.
just out of the bag, even though...
Bye-bye.
Cheers, Stan. See you next time, okay. Of course, it's great to get a good surgical result and to cure a tumour and have a patient who's seeing you many years afterwards having done very well. But in fact, there's other surgeons that can do that. I think what I can bring to the patients is bringing them into research studies and bringing their tumours into the research lab, because we've seen a rapid increase in tonsil cancers and tumours at the back of the tongue that we believe is caused by a viral infection. And 10 or 15 years ago in the UK we hadn't really recognised that. And in fact these tumours, this particular type of tumour is the fastest growing rise in incidence of cancer of any site in the body in the UK. I hope it's true to say we've been pretty pivotal in that, about getting some of the first evidence, driving the first clinical trial and trying to unpick the reasons for that. And some of these questions, what we've done, we've posed these questions in the form of other research fellowships. So we've got surgeons in training now funded by the Royal College of Surgeons who are doing their PhDs and their MDs, addressing those very questions and hopefully doing it innovative and really high impact work that's really going to change the nature of our treatment looking forwards.
It's quite rare for surgeons to be involved in research, and it's important that we're adequately resourced. And I think, you know, Professor Shaw and the group that he's got around him now really sort of stands testament to what the Royal College has provided. Hopefully I'll be able to progress through and provide the similar support for those that are coming training behind me.
It took some time to decide what I wanted to do, but essentially felt that this was perhaps quite a meaningful way to spend my clinical time, because treatment that we provide patients can not only cure their head and neck and oral cancer if picked up early, but in late stage disease it actually allows patients to have pride, dignity and also comfort if they require any major reconstructive surgery.
I have lost 35% of the left-hand side of my tongue, 14.5 centimetres of the floor of my mouth. I then had a right radial free graft where they go in and remove a piece of tissue from my right wrist and the radial artery and vein which supply that tissue, which is then, if you like, plumbed into my tongue and the major vessels which are in my neck. It makes you look at life in a by far more acute and deep way. You understand the fragility of what you actually have. It makes you appreciate the support of others and the team. I am back at work full time. I would not be here unless there was the research, the funding, the whole system which is actually there to be able to support me actually getting here.
Thank you very much for your help. Thank you very much for your help. So we'll get an appointment 3 months. Yes. So looking back at critical things that have helped me get where I am today and be at the centre of this very exciting research group, they're probably critical moments. And one of those critical moments was getting that phone call from the Royal College of Surgeons to tell me that I was the Freemasons Royal College of Surgeons Research Fellow for that year. And that made a big difference to the direction of my career. And it's quite nice to think that you're contributing to the thing that's making a difference in 10 years or 20 years or 30 years' time, and you're investing some of your time to improve the outcomes for patients in the future.